sir.
Speaking of like managing pain, like are there any ways to manage pain caused by fibromyalgia and
Yes.
stuff like that?
Very good question. Yes and yes and yes. There are very many ways to manage fibromyalgia. Let me give you the bad news first. We can't cure it. There's really no cure, not only for fibromyalgia, but not for chronic fatigue syndrome either. These two usually go hand in hand. So we can't just say, hey, take this medicine or do this lifestyle change or Institute Bob 2 where the weather is different. I don't know. There's nothing that we have in our bag of goodies right now that would actually eradicate what seems to be kind of coming out of nowhere. The condition of fibromyalgia seemingly, at least to this day, is coming out of nowhere. We don't understand why over a period of time. The muscles, but for the most part, the ending muscles where the joints and the muscle meet, begin to just out of nowhere become inflamed. We don't know why that happens. There's like so many theories out there that this could be an infection thing, it could be a viral thing. Lyme disease is considered to be like a sister Nicole of fibromyalgia. Lyme disease is another one of those interesting diseases where people are, the jury is out on it. But technically, it's about having had gotten infected by a mosquito. If you have Lyme disease, anyways, we don't know how fibromyalgia happens, but there's plenty. In fact, this woman that I was just explaining about, doing the flower bed and everything, the diagnosis is actually fibromyalgia. So there's plenty. So again, lots of behavioral changes, lots of usage of ice packs and cold packs, and even braces when they need arises. And of course, she's now an avid meditator. So everything that it takes for the pain signals to not get through to the brain, to just kind of like allow the gatekeeper to do a heck of a job in keeping the gates closed in terms of behavioral changes. That's the first start. And then second to that, again, cognitive changes. So in her mind, she had just called it quits. She was no longer considering herself a person that was worthy of me, let alone being further, let alone studying her flowers, let alone doing anything that was worthwhile doing. She's now completely looking at her perspectives in life in a different way. So the brain of a person who processes her pain as a nuisance that just kind of gets in the way of her doing stuff, versus the brain of a person who says, oh my God, I can't even do another day because I have this. You can imagine there's a significant difference between the two brains in terms of how deeply they process pain. I usually think of it in a pretty made-up way. I've just made up this whole thing in my own head. I would think that if you have like a little tray with like 10 little holes in it, and each hole is supposed to get filled in with a ball. If all 10 of them get filled in with a ball, you get that much pain reception. If you could find a way to only fill it up with like four balls and the rest go empty, that's great. And that's what you can do with cognitive changes, behavioral changes, perception changes. So you still have the challenge of even having to have a tray that has to get filled in with balls, but much less of them. So therefore, there will be much less suffering because of this. Yes, ma'am.
This is having someone go through this seems like it would be a very, not only a psychological, but like a philosophical challenge.
Yes.
To like accept your pain in to just accept pain and not, there's no, there's a cause, but you're not necessarily
chasing after your tail trying to eradicate it. Yes.
Right, or yeah, like looking for it and then, it's not the cause of your symptom.
Correct. You're right on.
And you're not, and it doesn't necessarily have a meaning attached to it. Like you're like watching the meaning, right? So I'm wondering if there's a difference in the people's lives before they experience the pain, during the pain, and then after the pain. So I guess I'm interested in the before pain, after the pain, but that's not.
From the perspectives of their perceptions about life.
Yeah, exactly. Like, did they?
Yeah, when I used to be in graduate school, I was taking this class called History and Systems, and I was with this professor whom I just loved, and we spent endless hours talking about hermeneutics and just fun stuff. And then one day he came and said, you know what, I really liked you a lot because you were slightly depressed. I was actually quite depressed back then. My brother had just died. And I just couldn't get over it. I still am not over it. It's been 12 years now. I was very depressed. I was a pretty depressed woman walking around campus and just trying to stay alive. But this man saw that and he said, I love it because, oh, I don't know, when you want to look depressed, for some reason you have a better appreciation. You just get things in a deeper way. You're cool. And I said, may I ask if you were depressed? He said, oh yeah, I've never been not depressed. So, kind of coming back to the question that you're saying, if you have experienced trauma of any sort, chronic pain or pain is traumatic, it's another experience of stress and trauma. If you have experienced trauma and you have learned to kind of live through it and come out the other end, I would imagine that by most virtue you are a more philosophical person or someone who, oh, I don't know, can maybe wrap their mind around issues in a more flexible way. Some people call that a deeper way. Yeah, there is something to talk about. I guess it's one of the situations where we say ignorance is bliss. So persons who've never experienced trauma or who've never experienced pain are just blissful in a blissful state. But when they have experienced this trauma and they have come out the other end, there's something about them that says they're not as ignorant. Not everybody, of course, but yeah.
There are studies that say that people who are depressed see the world as it really is.
Yeah.
And the rest of us are blissfully ignorant.
When you look at cognitive material, cognitive behavioral therapy, the argument is that there is no such thing as reality. It's essentially the way you see things. So if your perceptions of the current economic status or whatever that the case might be, if your take of it is that it is catastrophic, we're all doomed, and this bad thing is going to happen, I'm going to lose my job, and I'm going to have nothing left for my kids, and then what are they going to say about me? If you are continuously consumed with this particular perspective that is rather negative, then the reality is awful. And instead, if you look at it as, oh man, wow, geez, I suppose this is another way for me to think about how to expand my business. I used to think that I could just do a 9 to 5, retire at age whatever, and that would be that. Now, come to find out, I really need to be expanding my horizons. I need to think about different ways of making money. So that's kind of okay. It's kind of interesting as that time. But now that's your reality. You're turning into an entrepreneur. So, I don't know which one of them is the real deal. So CBT says, take what suits you. Take what actually makes sense for you. And if the one that makes sense to you is the one that leaves you depressed, by all means, stay with it. But if that's suffering and you don't like it, might you consider changing or diving it down a little bit? That's really just in a short said, the definition of cognitive behavioral therapy. Okay. Well, is this it, or how are we doing?
Any other questions?
Thank you. I'm in private practice. I'm a health psychologist. The name of my practice is Medical Psychology Services in Capitola. And what I do as a psychologist is help individuals with ongoing chronic health conditions. I specifically have an age for chronic pain and the condition of chronic pain. And where that comes from is pre-doc internship and a postdoc fellowship at UCSC and at Kaiser in San Francisco, Department of Pain Management. Turns out that pain and the concept of pain has a whole state to itself. It's got a little chapter to itself, separate on the statistics of what chronic pain looks like in our country, how has it affected us as a nation. Then we'll be talking very briefly about the psychophysiology of pain. It wouldn't be such an in-depth conversation because textbooks do a much better job than I would in the brief period of time that we have here in terms of explaining how does pain take place in our brain and then how does our brain react. But I will kind of brief you over what that is like. And then we'll switch over to the concepts of where psychology and psychotherapy and the cognitive behavioral interventions come into picture when you are sitting with somebody who suffers of chronic pain. My guess is that by then we'll be kind of done with the lecture time. We might just break for 5 or 10 minutes if you guys need to. And then when we come back, it'll be Q&A or probably about half an hour or so. So that would be kind of the way I would probably break this down. And please do feel free to raise your hand and ask questions even as we go. It's rather informal. It's not that. So ask questions as we go. So I'm going to go ahead and start with a definition of what chronic pain, or for that matter, what pain is. Pain has been defined in many different ways. I picked up this one. It's by the International Association for the Study of Pain. You probably may note that it's going to be a rather provocative or at least thought-provoking description of pain. If you are in pain yourself, have experienced chronic pain, or know somebody who has, this particular definition may stir up some thoughts or emotions. I actually invite you and encourage you to take this in and to begin forming an opinion about this. I'm hoping that during Q&A or at some point you will talk about what thoughts have crossed your mind or what emotions you have experienced after reading this definition of pain. It says that pain is an unpleasant sensory or emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Pain is always subjective. See what you think about that. Each individual learns the application of the word through experiences related to injury in early life, or for that matter, any time in life. It is unquestionably a sensation in a part of the body, but it is also unpleasant and therefore also an emotional experience. Many people report pain in the absence of tissue damage or any likely pathophysiological cause. Usually this happens for psychological reasons. There is no way to distinguish their experience from that due to tissue damage if we take this subjective report. So I can imagine that some people may already have formed some possibly even negative reactions to this, as in like, do you mean to say that pain is only in our head? Do you mean to say that pain doesn't exist? Let's take a look at that together. This will come up as we go on. Let's take a look at what pain has meant to our society altogether in America. Approximately 600 billion people, $635 billion have been spent on the cost of chronic pain. This is a combination of the care, the medical care, and the psychiatric care, as well as job loss and wages loss and disability costs, and basically what it takes to not go to work and to be ill and to go to the doctors. $635 billion, and this is in today's dollars. It's also estimated that approximately 20% of all Americans don't sleep at night because of pain, or sleep poorly at night. As you probably know, sleep is one of the most fundamentals of health. And if you're not sleeping, that's one out of 5 people not sleeping at night because of pain. It's also being estimated that better than 50% or more than half of the people who are hospitalized in an end-of-life circumstance are going to die in moderate or severe pain. And this is despite palliative care, morphine, everything that we can give them to kind of ease off the pain. But a good chunk of us actually die the last days of our lives, last years of our lives. It's a toll on the rest of us. So there are some major diseases that all think about in our community, for example, diabetes, coronary heart disease, stroke, cancer. So when you're looking at chronic pain in comparison to these other major diseases, okay, the first one is diabetes in terms of the number of people that are suffering from it. Almost 26 million people are suffering from diabetes in this country. But then right next to that, we actually have the chronic pain people. 116 million Americans are suffering with chronic pain. And then you have 16 or 3 million with coronary heart disease, 7 million with stroke, and about 12 million with cancer. So it just puts it in perspective. Chronic pain is not something that only some small number of people in the population experience. It's really hefty. Some more statistics. Usually when you have someone with chronic pain come in the clinic, they don't just have this one kind of pain. Most of the times they have a variety of pains that they would be complaining about. But for the most part, low back pain is the most common type of chronic pain that people talk about. Next to that, you have your headaches, either migraine headaches or the stress tension headaches or even cluster headaches. That's about 16% of the population. And then you have next to that neck pain, and then knee pain, and shoulder pain, and even finger pain, and hip pain. And you see the percentages. But lower back pain is probably the most common presentation of chronic pain. The saddest part is that our kids, ages 4 to 18, about 72% of them experience frequent or rather severe headaches. Even minor headaches are now diagnosed in the pediatric population. This is within the course of a year. Before they hit puberty, girls and boys are about the same in terms of how often and how much pain they talk about. Once they hit 12-ish, guess what? Girls report more pain than boys. That trend continues. Women are more likely than men to experience pain in the form of migraines, neck pain, lower back pain, face pain. And when it comes to migraines and severe headaches, women are twice as much likely to experience these pains than men. And yes, there is an inverse relationship with age, so the longer you live, the older you become, the more likely you are to experience chronic pain or pain for that matter. When it comes to races, it turns out that Asian adults are least likely to report chronic low back pain, which is the one kind of pain. Your other races, your whites and your blacks and your American Indians and Alaska Native adults, are reporting higher incidence of low back pain. I'm not so sure as to why that's the case. Education pays off. It's good that you're in school. People who have at least a bachelor's degree or higher are less likely to have migraine headaches, neck pain, or lower back pain, or even face pain, compared to individuals who have a high school education. And being poor also doesn't work too well for health conditions, especially pain. The poorer the family or the individual, the more likely they are to fall into the large incidence of having chronic pain of some sort. Comments or questions so far?
Yes, I was wondering if you could explain to me the difference of a migraine headache, because I know that there is a bit of a nuance for a lot of
The difference between migraine headache and the other type of headaches? Yeah. Technically, there are some differences, but in reality, in terms of what does it take for the person who's in pain, it's not a whole lot. Pain is pain. But when it comes to cluster headaches, there's a part of the brain, or a part of the head actually, maybe just like the one side of the eye, or the one corner of the head, or even the one corner of the back of the head that hurts, but not systemically. So it's a cluster of pain. Migraine headaches are having to do with the opening and closing of the of the vessels essentially inside. And it is usually accompanied by GI upsets and photophobia, which And tension headaches are essentially musculoskeletal, which has to do with the muscles on the scalp, not a whole lot to do with the actual veins inside the scalp. So the muscles, in fact, can go kind of spasm. That's how you get tension. Sure. So I'm going to spend a little bit of time now talking about the construction of pain, or essentially the physiology of pain. And like I said, this is just a watered-down version of what pain literally looks like. For better descriptions and a deeper understanding, fantastic textbook or any other library resource would probably get into this. But suffice to say that the body senses pain or painful stimulations through certain receptors that are located anywhere in the skin, on the joints, inside the body, right? And there are these specialized nerve fibers that essentially send the signal of pain from anywhere in the periphery, wherever the pain has happened, to the brain. And that's how we become conscious or we become aware of the fact that there is pain. We have a referee in between. Let's say there's the body, anywhere in the body, right there inside the body that's gotten hurt and now there's pain. And of course there's the brain that's sitting at the top supposed to be perceiving the pain. We have the spinal cord in the middle that kind of begins to play a little role, or actually a significant role, as to how much of this pain actually gets to go up, how much of it actually gets to be sensed and processed. So it modulates or plays, like I said, the role of the referee. It gets to tell how much of it actually gets to go and how much of it doesn't. You'll see more about this in just a moment. So we call that a pain filter, the spinal cord. This filter assures that the pain is not evoked by everyday stimulation. So for example, it's the spinal cord that lets the brain know if it was just a stroke or just a small touch or a little pressure or like somebody stabbing you. It gets to tell by modulating the amount of pain that gets to go or doesn't get to go. So as I said, these signals move toward a section of the spinal cord that is called dorsal horn. This dorsal horn is essentially like a gatekeeper to the central nervous system. We used to have this thing called the gate theory of pain. Anybody has ever heard of that? Yes. It's a rather common and old and well-known theory. We're not exactly ruling it off still. We're still talking about the gate theory of pain. It used to say what we're still saying here, that some pain gets to go through the gate easily, some pain doesn't, and that there is a mechanism of the gate that allows X amount of pain to go up or down. So what is that mechanism? The filtering is accomplished by inhibitory nerve cells that are located in the dorsal horn. And you probably have experienced neurotransmitters at this point. Have you? You probably have an understanding of neurotransmitters and the synaptic exchange of any neurotransmitter. GABA, of all neurotransmitters, is the one that is at play. So the amount of GABA that gets produced at the production of one synapse or one nerve ending to the other, and then to the other, to the other, is really what's the modulating goods. It's the stuff that gets to tell how much of this pain gets to be felt or not. So like, for example, the other neurotransmitters are norepinephrine, serotonin, dopamine. You probably have heard about the roles of these neurotransmitters. Some of them have to do with our mood, and some of them have to do with the level of excitement that we experience. GABA, among many other roles that it has, is a modulator of sensory information that gets to travel through the spinal cord up to the brain. In patients with chronic pain, there is inflammation in the tissue and in the cells. This inflammation, for example, in rheumatoid arthritis, causes nerve damage after the injury has happened. And so therefore, this is one of the factors that gets in the way of the production of GABA. It's like an inhibitory action. GABA does not get to produce itself as much as it normally would. So what would happen? The person will get to experience pain more so than a person who has not experienced pain on a chronic basis. So basically, you may think about GABA's role as a way to kind of like modulate and quiet down pain signals. But when pain is going on and on and on and on and on, in case of chronic pain, it wears out. GABA says, I give up. So more and more pain gets to be they actually transmitted to the brain. So the pain signals that are conducted to the brain are going medially unfiltered. Are we good so far? Yes, ma'am.
Is that suggesting that there's constant pain without GABA? I mean, meaning,
In the case of chronic pain,
but if you didn't have any injury but still lacked GABA, be in pain.
there's no such, that I know of, there's no such disease or condition that causes a person to just not produce GABA. But here's what does happen. When there has been injury, and I'm about to talk about it in a second. When there has been injury, or when there is any kind of other nerve disorder that I will be talking about in a second, yes, GABA gets a good hit because of a number of different reasons. And then yes, essentially, it's not only GABA that is at play, but GABA is one of the main neurotransmitters that gets to go haywire. And then the pain transmission takes place without any filtration. So, yeah.
Is that why alcohol can have some anesthetic properties because it's the basic GABA in the brain?
You're right on. Alcohol has quite a role similar to melatonin. It also plays an inhibitory factor on the prefrontal and the frontal cortex, and we'll talk about that in a second. So even if GABA doesn't get affected and pain does get there, the brain will say, oh well. So you wouldn't process it, it wouldn't mean as much, you wouldn't make a big deal out of it. I'm just using my language, but the point is that the thought processing of what the pain means will be like, so you can do that well. For that matter, narcotics is something that it makes us Come again? Concussions. Slightly different story. Concussions, if they cause any kind of nerve damage to where it's like broken or severed or essentially like gone, you don't get to hear it because it's not transmitted. Other reasons why I have concussions call for just kind of like falling out of consciousness for a while has nothing to do with pain per se, but it has to do with the body refurbishing itself back to a pre-thermostatic. It just tells the body, stop breathing and then reset itself. During the time that it's out, you don't do it.
I'm saying because I'm like injured myself and had concussions, but like the pain of, because I hurt my elbow, the pain of my elbow didn't really hurt because I had a concussion.
Yes.
So like how would that like, and like the pain is something besides in your head.
Okay. If I'm hearing the question correctly, how is it that we fall unconscious because we have a head concussion, or how is it that we...
How is it that I didn't feel pain in my elbow because I had a concussion?
Oh, okay. I'm going to talk about that in just a second. There's also going to be, the short of it is that the brain says so. This is the other way around. I'm about to talk about that in a second. So we get to feel the pain going in from the periphery through essentially the spinal cord to the brain. But pain doesn't only go one way, it'll also come in the other way. Sometimes the brain will say, I don't care that there's pain. Sometimes the brain will do everything in its power to quiet down the pain. In the case of veterans in the war, or persons who are about to have a touchdown, or at a time when it's not okay to be that debilitated with pain, the brain just kind of releases hormones that are very, very anesthetic. They kind of take the place of even anesthetics that we get in the hospital. So you don't feel the pain right then and there. You will later. I don't know if that answers your question.
Yeah.
Would that be an adrenaline rush?
Very similar. Adrenaline is one of the hormones that gets released at the time of stress, and of course pain is another type of stress. So yes, as I was saying, there is a two-way relationship between the spinal cord and the brain when it comes to processing pain. On the one hand, there is this ascending pain pathways that goes from the body, anywhere in the body, to the brain. But then there is also this descending pathway that allows the brain to also modulate pain. Let's take a look at how that works. The brain uses this pathway to send chemical substances as well as nerve impulses that go back down to the cell in the spine or in the spinal cord that will also act against the pain messages. So the primary role of these descending pathways is to send chemical messages from the brain to also close the gate. So I know that a minute ago I had said that the gate closes only through the production of GABA. I was kidding. Nothing in the body works as statistically getting that one-way production, but that's one way that the GABA produces and the gate closes. Another way is that the brain now tells the same structure in the spinal cord to close off. So there is essentially a two-way relationship between the brain and the spinal cord when it comes to processing pain. Are we still good? When it comes to acute pain, how many of you know the difference between acute pain and chronic pain? Yes, sir.
Chronic pain is just less than 6 months. That's one of the differences.
Right. Yes, there's a arbitrarily set time frame where they say pain that lasts longer than 6 or shorter than 6 months is considered acute. Beyond that is considered chronic. Any other thoughts or any other, whatever you have heard about the difference between acute and chronic pain? I have one. Acute pain is like, oh shit. It hurts a lot. It's sharp. It's well distinguished. You know where it's coming from. You can tell where it's coming from in the body. And the duration of it is relatively short, the way that it's that sharp. As soon as it turns into something dull, and achy, and kind of rubby, but you don't know, you don't know where it is, but you know about the region, or where about the region. It doesn't even take 6 months to know that, maybe about them. And it's beginning to have the qualities of chronic pain. Anyways, there's a lot more to be said about chronic pain and acute pain. But anyway, so back to acute pain. When you are in an acute pain state, the brain has this thing about keeping you alive. The brain has this thing about bringing you back to safety as soon as possible. One of the ways that it does that, and remember a minute ago I was saying how the brain also sends in modulating signals to stop the pain or to lower the pain. One of the ways that it does that, or among the many ways that it does that, is that it serves nerves from messages to the nerves down to the nervous system to begin a healing process. For example, to limit the amount of blood that would be flowing. If you have a cut, you don't need a whole gush of blood going in. You're going to use too much blood. That's something that the brain regulates and says, not a whole lot of blood to this cut. Or if you're having an area that is probably compressed under something very heavy, the brain will be sending in the brain will be saying, let's just go ahead and send in a little more oxygen to this particular set because it is under stress. Another way that the brain would be helpful when it comes to having an incident of acute pain would be by releasing chemicals that suppress the pain. That's where the adrenaline comes in the picture, or even from the category of adrenals. That's purely by the order of the brain where these anesthetics begin to produce in an acute setting. But with chronic pain, it's a whole different story. Essentially, the brain will kind of check out. The brain will not bother itself with the regulation of the pain. As a matter of fact, it will not even bother itself with the slowing down or regulating the amount of pain that gets to be brought in. The brain will say, oh well, whatever, this keeps happening every day. I can't bother myself with this. I have more important things to worry about, such as staying alive. So with chronic pain, nerve messages do not always work their way back down the nervous system. In fact, what happens is, for the, like you probably have heard of fibromyalgia, it's a chronic pain disorder that usually affects people in their joints and sometimes in their muscles. In the case of fibromyalgia, for example, the nervous system has a decreased ability to send signals from the brain to inhibit the pain. The pain continuously gets to the brain. So I'm going to talk just a little bit more about what happens when pain gets to the brain. So you stub your toe, or you got shot by a gun, or something happens. The pain will get to the brain, but without it getting kind of distributed amongst the different parts of the brain, you wouldn't know what it means. You wouldn't have any significant meaning of it. If you just say pain, 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 the brain wouldn't even know where. It could be like the middle of your finger here, or it could be the small toe, or it could be somewhere back. So without this part of the brain that we call the somatosensory system, we wouldn't even know where it hurt. The thalamus is this area of the brain where it says, okay, it's hurting, but we don't know where. The somatosensory system will say where. That's really important to know. There's another region in the brain that is called the limbic system. Anyone has ever heard of the limbic system? What happens in the limbic system? What's the essential, most important thing that gets processed in the limbic system? Our emotions. Our emotions. So if I get hurt, like the other day I was trying to capture my son's karate. He was getting a new belt. And he was great, it was wonderful. I was trying to go ahead and capture him that very moment that he was getting his new belt put on. And I don't know what happened, I wasn't looking, and I stumbled upon something. I was wearing a pair of sandals. And my big toe, my nail really got caught in something. And anyways, it was awful. My nail just got caught on the nail. It was just really painful. It was really awful. Meanwhile, I have this important thing I need to do. I need to capture the moment with my son, right? So I'm just hoping that I'm not leaving a trace of blood as I'm walking. I'm like, oh shit, I'll just worry about this later. But right now, I need to capture this, right? So my emotions in the limbic system was telling me, don't worry about it. We'll see about this later. Right now, I'm fully awake with the excitement of this other thing that's going on. Later on, though, I feel like, oh my God, I can't even move my toe or my foot altogether. This is when I get to sit down and really feel the emotion, the sadness, the upset, the disappointment, the fear, the whatever that emotion is called. That's just happening. So the limbic system gets to translate what this pain means to us. Similarly, where we do our thinking, where is going to we do our thinking? Is it in the back? Is it in the side? Is it in the front? Do we even think through our brains? It's in the frontal and the prefrontal cortex, essentially the frontal cortex. This is where the thought processes take place. So when I have pain, I'm supposed to have some sort of a thought behind it. I'm supposed to make some sense out of it. So for example, if I'm in a wrestling match, arm wrestling match, and it's hurting so bad, I will just write it off with the thoughts of, at least I'm winning, or it looks like I'm winning, don't be a child. Or if I'm in an aerobics exercise class or some sort of exercise class and everything hurts a lot, but the teacher is like, yeah, that's great, keep on going, I would imagine to myself, okay, this pain is good pain, I'm doing something good for my body. So I'm making some sort of a meaning with the thoughts that are associated with the pain that I'm experiencing. If the thought was, I can't imagine that I brought myself in this class where this teacher is just torturing me, or I don't belong here, I don't want to be here, the stage is so uncomfortable, whatever. I can't stand this anymore. So negative thoughts, if I phrase the circumstances in such a way that is negative, then I will obviously have a different reaction about what that pain is. So all pains are not created equally. It all depends on what happens to it when it gets to the brain. Part of it gets to be processed as pain. Part of it gets to be processed as to where is the pain. Part of it gets to tell you what does it feel like that now that it has this pain. And the other part is like what do you think about this pain? What is your feeling about this pain? Let me now pause for a second and kind of bring us back to that definition that I got earlier. Let's see if that's now going to make sense. He said pain is an unpleasant sensory or emotional experience associated with actual or potential tissue damage. And he said that it's described in terms of such damage. Pain is always subjective. Do you now see how that might be the case? We just described how pain gets into the brain, but then depending on what you make out of it, it means something or the other. So pain is essentially a subjective In other words, my pain is not the same as yours. People describe and define pain in different ways, and all of it is correct. So the doctors or the nurses or the spouses or nobody else gets to tell what is it really like for the person who is experiencing pain. Okay? Any thoughts or reactions to that? Okay. So it is our awareness of pain that involves a combination of sensing, feeling, thinking, and even our past experiences that get to tell what this pain is really all about. Now I want to take a few moments and talk about this process of nociceptors and nociception. It's a big word, but it really doesn't mean a lot more than what it's not that scary. The term nociception refers to the process by which pain information is carried from the periphery sense receptors in the skin and in the viscera to the cerebral cortex. It's just the way that the pain gets transferred from wherever in the body, inside or the outside, to the cerebral cortex. And it is done through a network of neurons. And then we basically have two kinds of nociceptors. We have the exteroceptors, which are on the surface of the body. And then we have the proprioceptors that tell you what's going on inside the body. So pressure, mechanical changes, electrical changes, even temperature or thermal changes, these kinds of nociceptors get to tell the brain what's going on. But what's the big deal about this? So these nociceptors are fibers with millions of nerve endings that sense the uncomfortable sensations, such as a touch, or sense of huge pressure, or pain, or burn. The ones that are inside the body, the nociceptors, the proprioceptors, they sense inflammation. So for example, when you have diseases that cause inflammation, such as rheumatoid arthritis or chronic back pain, anywhere in the body where there is inflammation, the way that the inflammation gets transferred to the brain is through these internal nociceptors that we call proprioceptors. But when these sensitive nerve endings detect something that is harmful, they send electrical impulses through the spinal cord by the way of chemical messengers we call neurotransmitters, we call them like that. And as we said before, they go through this part of the spinal cord named dorsal horn, which is essentially a gatekeeper of the center. Now, all of these messages try to get through the gate. The good ones, the bad ones, the big ones, the thin ones, the ones that hurt a lot, the ones that actually feel good. But here's what happens. Emergency situations, when there's acute pain, the gate opens wide open. Why is that important that the gate doesn't modulate? Somebody's cutting your arm off with a saw. Why is it important that the brain feels it all instead of not? So you can do something about it. But when it is like a dull, achy pain that is more of a nuisance than not, yeah, I can see how the job of that gatekeeper would be appreciated. But what's so beautiful is that the body knows the difference. It knows the difference as to when to open the gate wide open and when to kind of shut it down. I like that. I think that's pretty cool. So much talking about the nerves. There's some stuff that's probably getting on your nerves. I got to thinking maybe I should do this topic. So we have a bunch of idioms in English language, right? We say you've got a lot of nerve. We say he gets on my nerves. We say you just have a case of nerves. So it turns out that the word nerve, depending on which era or which time you look into the dictionary, happens to have had different meanings. Back in 1601, it meant boldness. Later on, it was called courage. A bit later, it was called nervousness. At some point, it even meant things. Just thought you might have known. Pause for a second. How are we doing? Questions, comments, confusion? What the heck are we talking about? Okay, so we carry on talking just a bit more about chronic pain, and I promise I'll be talking about cognitive stuff that's more like everyday. How do you know this? Chronic pain is not just a slower version of acute pain. It's a whole different role class. It's a whole different way of pain being perceived in the body. Nerve cells in the spinal cord change and become, first of all, even mechanically change. The fibers or the nerve ending cells that have been experiencing chronic pain look different under the microscope than they do when they are not experiencing pain. Nonetheless, they become hypersensitive, so it doesn't take a whole lot more of pressing them or even firing them. In fact, sometimes it doesn't take anything, any stimulation, for them to respond and to be sensitive towards pain. In other words, what should have been just a temporary condition, just a small little change to the structure or to the mechanical and also to the chemical structure of the cell because of some sort of damage, now becomes more or less like a permanent change in the cell, which essentially changes the nervous system. It sometimes doesn't even take any new stimuli. For persons who have chronic pain, spontaneously pain can fire from one synapse to another, from one nerve ending to another, and then suddenly they're having a breakthrough pain on a Wednesday morning. It's not because they lifted something heavy. It's not because they slept on a bad mattress. It just happens. That's, I guess, the bottom part of it. So, certain conditions like neuropathy is the kind of pain that people with diabetes experience. Sometimes when people have shingles, you probably know what shingles are, right? It's very painful. It's a very painful experience. It's usually right around the periphery of the spinal cord. But when shingles gets better, about a month or so later, the pain of it, which is very excruciating in most cases, stays. So those kinds of nerves, it's not because of nerve damage, if you will. It's not like they got cut. It's not like they were in an accident. But these kinds of nerves stay around. These are by definition nerve. These are by definition the stuff that I'm talking about. It's chronic pain that is not secondary to anything that just happened to the nerve. The nerve is just firing pain, but when you look at it, it looks intact. It looks just fine. That's where it becomes really confusing for the physicians too. We kind of call that kind of pain neuropathic pain. And it's basically a wastebasket or a garbage bin for pain that doesn't make sense medically speaking. So, neuropathic pain, the type of pain that lingers after the original injury or not even because of an injury at all. Neuropathic pain is hard to diagnose because the pain results from abnormally functioning nerves inside the body, usually not because of some sort of an injury directly to that issue. Sometimes people describe, in fact, this is quite often, if you ever work in a pain clinic or if you ever sit with pain patients, they describe the sensations associated with what we call neuropathic pain as pins and needles, or kind of like a tingling, even numbing kind of pain. Or sometimes they describe it as if I'm walking on glass. Sometimes they call that it's like, especially in the lower back, it's burning, or it's kind of like hot. It feels even hot to the touch sometimes. They also describe it as electrical shock-like, like that type of pain. So I've never experienced that myself, but I've listened to enough people to almost imagine what's it like to have neuropathic pain. It's no fun at all. And unfortunately, if you live long enough, it's quite likely 1 out of 12 people beyond the age of 55 are probably going to experience neuropathic pain of some sort. The damaged nerves, not the original injury, are often the cause of that.
And this is something that would come after a battery of tests have been done and things have been moved
Yeah.
like that.
Yeah. The question is, where does it come from? It's usually after all the diagnostics are done. This is where the patient is very angry. This is when they are sent to the psychologist's office. And they call and they're so upset and so angry that they have been referred to me of all people. I'm telling my doctor that I have pain in my back and he sends me to a psychologist. Excuse me, doctor, but I'm not crazy. I don't know why they're calling. What, you want to talk about my childhood and my spouse and my kids? Yeah, I've got problems beyond the walls, but that's not even talking about my back pain. And the doctor is at their research going, well, as far as the world of medicine is concerned, we've given you all the shots, we've given you all the medicines, we've even done surgery. There is nothing more that I have in my bag of tricks to offer you. So go see insurance.
Is there any way to measure that? Like with skin response or with anything?
To measure the actual amount of pain.
Well, I mean, like a metal detector or something, to go in and actually see if you can locate it.
Yeah.
And to actually get some type of device to register it. If it's
Yeah.
real.
Yeah. So as I have described before, it turns out that pain is a condition that, of all the other conditions, or compared to the other conditions, other diseases, if you will, is not to be illustrated by medical measurements. I'll tell you why. So we have had all kinds of studies that actually show this, and it's kind of interesting and also kind of thought-provoking. So they have had studies taken from, like with x-rays, taken from backs of a whole bunch of different people, regardless of whether they are reporting any kind of chronic back pain or not. And then they have separated the slides. And they have said, there is a slip disc in here, there's a herniated disc in here, there's a whole lot of inflammation on this particular back. These people are probably reporting a lot of back pain. Then they go back and talk to people and ask, do you have pain? Nah. Do you have pain? Oh my gosh. You have no idea. Then they have paired the responses of these people to their actual back features. Guess what? They don't jump. Somebody with a herniated disc that looks like it's just slipping off any second, who might be experiencing physically all kinds of pinched nerves because of that condition, is going about their life, or they're reporting a pain scale of 1 to 10 at 2. Wonder. And someone who's got a pretty good stacked up back, no inflammation, no redness, no activity, so to speak, and they can't bend down like 20 keys. It hurts. Pain is very subjective. So, and the funny thing, by the way, is everybody's looking for a diagnosis. Everybody wants to have some sort of an affirmation or confirmation as to why they are in pain. And I get that. I would too. It's very frustrating when the doctor says, well, I don't know. Go talk to a psychologist. Pain is not only to be shown or to be detected by the medical test. It has to do with what I said earlier, the 4 processes in the brain. What do you think about it? How do you feel about it? Where in the body are you sensing it be? And then what kind of damage are we talking? So if it's like, for example, neuropathic pain, it's not exactly based on nerve and damage to the nerve. It's got to do with the weird firing of the pain signals that is just haywire. So it's like a mix-up. That's not something that can be shown even on an fMRI, let alone on an X-ray. Was there a question? Okay. So I also wanted to bring to your attention that in addition to the stuff that I've just talked about, there are diseases of the nervous system. There are nerve disorders. They usually happen off of one of the 3 reasons. It would be because of toxins or toxic material in the body. You've probably heard of the damages or the worries of mercury and fish that sometimes you take. What's wrong with that? Well, the way it works is toxic substances interfere with the sodium and potassium channels. You probably remember from one of your psych courses, potassium-sodium channels open and close in a very systemic and rhythmic way in order for the synaptic exchange to happen. It's like an electrical opening and closing. Well, it turns out that mercury interferes with the proper opening of the channels. So the sodium-potassium channels don't open the way they should, so the nerve connectivity doesn't happen. So the stuff doesn't really travel the way it should. That's one way that you experience nerve disorder. Trauma, as we have talked about before, when there has been a whiplash in a car accident perhaps, or when you have fallen, or when somehow or another, even just through regular wear and tear of life, a nerve has been pinched or even severed or damaged. You experience numbness, pain, so that's a given trauma. Experiences of pinched nerves, you've probably heard of people having they have sciatica problems. We've probably heard about carpal tunnel syndrome, people typing a lot. Those are experiences of pinched nerve conditions. And then there are some other diseases, for example, going on in there is that, again, not to get into the detail of it, nerves are, if you think about the cables of, that white cable there, cables of electricity, we usually don't just have them by themselves, we usually have some sort of a sheath or some sort of a cover over them. That is to protect them from doing all kinds of weird stuff. In the body, nerves are covered by this thing we call myelinated sheath. When they're myelination, it's sort of like a little slimy material that covers the nerves. If the myelination or the cover of the nerves aren't there, or slightly there, or worn out, or some form of it not there, the nerve conduction, again, that the signal between the nerves takes place in a weird way. So there you want to make that's easy. That's not something that you bring onto yourself. MS is something that is essentially hereditary. Okay? So the name of the game for the future is gene therapy. All this cutting people in surgery or even doing laparoscopic interventions or giving them medications, this stuff is almost going to end, most likely even in your lifetime or at least in the lifetime of your children. We're looking into gene therapy as a way of medicine. Medicine is headed towards that direction. We are looking into the causes of what makes these things happen, all the diseases that we have, and we're looking into treating, again with medicine, but we're treating the genes that set off the beginning or the presentation of these diseases. Already there have been genes identified that set off neuropathic pain. So right now we're working on defining medications and substances that are going to stop the gene that triggers the beginning of this weird way of the nerves getting damaged and then firing in that pathway. There are also tests, exactly not very successful, but there are tests. There's a test that is called STEP, developed by the American Academy of Neurology, and it kind of just tells the difference between neuropathic and non-neuropathic pain. It's important to know so you're not treating the wrong thing. But most importantly, it's that awareness of pain, which involves a combination of sensing, as we said before, feeling, thinking, and even past experiences. If you have that awareness, if you know what's going on, quite likely you have a whole lot more working for you when it comes to the treatment, or at least having a little bit less suffering of pain. That is, you're drawing the line in any of these areas about the pain. I'm going to skip over this one over fast. I'm a nerve junkie myself, or actually a brain junkie. I just love looking at these weird pictures. This is a picture of a brain that's sitting in a museum in Bristol, England. It's the brain of a human being. The average human brain is about 2% of body weight. And it's typically kind of beige, pink, kind of off-white. And this is a good mock-up that shows how the brain situates itself inside the skull. So it's the real brain. That skull, as you see, is not a real one, but it's a very good showing. So if I'm standing here like this and you're looking at my head, this is what it looks like. This is another picture of the actual human brain. It's made of approximately 100 billion nerve cells that we call neurons. The cortex, or essentially that outer covering, it can be seen here. It is folded to allow the large surface area of the brain to fit inside the skull. Have you guys ever touched the brain of an animal or anything? It is so mushy. As soon as you pinch it, it just falls apart. It is very slimy. Like most of you got enough yet or no? So we have this thing, it's really miraculous, this, the outer metal of the cortex. It is more like a plastic wrap that you put on a Tupperware where you have like a meal inside. It covers the brain in such a way, it's kind of tight, and it holds what's otherwise this slimy material of the brain together in such a way that is exactly fitted for the inside of the kind of skull that we have. So we don't have kind of like brain going around like that in there. It's kind of like tucked in very nicely inside this bag. This one is the brain of a 3-year-old child, a small portion of the brain of a 3-year-old child who had to have surgery, and the brain sitting in the hands of the surgeon that just did the surgery. The surgery is for this one particular disorder where the child unfortunately has seizures very frequently, actually by the minute. So nowadays, this is still, after all said and done, this is still the way to treat uncontrollable seizure disorders. We remove a part of the brain. And then we deal with the consequences of that, but at least they're not having seizures all the time. So this is when the doctor has walked out of the surgery room. This is like fresh coming out of this bulge. I'm just wanting to go ahead and bring to your attention what's it like to see. Yes, ma'am.
I was going to ask, what are the major concerns or consequences of that kind of procedure?
This right here?
Yeah.
Oh my goodness.
I mean, I'm sure there's a lot.
It's a lot. So it's like taking the lesser of the two evils.
Yeah.
A child or anybody, but if you're such a young person and you're having seizure disorder in such uncontrollable way, quite likely you won't even make it. But the learning processes that need to be placed, just so many different problems take place that in the end makes it worthwhile to remove a part of the brain and then to recondition the brain for the stuff that's now not knowing what to do.
Yeah, I was going to say, when that removes part of behavior.
That's right. Oh yeah. Oh yeah. Lots of very obvious behavioral changes, cognitive changes, processes in your learning, speech, recognition, memory, vision, related vision, and all very well affected. But apparently, like I said, taking the lesser of the two evils, and apparently that's worth it than leaving it behind.
Don't they still suffer the focus also?
They do. They do. The question is, do they still severe sort of the brain is actually essentially two parts, as you saw in that other picture. Sometimes they kind of go in the middle, and they kind of either crack or you take out a part of the middle of the brain, and that is to kind of get in the way of what's otherwise communication between the left and the right of the brain. And that seems to help with seizure disorder as well. I know that I'm running out of time.
Hit the button on this computer.
Oh, so that happened. Is it on?
It doesn't.
Oh. Let me just read this out to you. This is a typical protocol of having a pain patient come in. This is a pain patient talking. I have a master's degree in clinical social work. I have a well-documented illness that explains the cause of my pain. But when my pain flares up and I go to the ER, I'll put on the hospital gown and I use my social status and my identity. I'll become a blank slate for the doctors to project their own biases and prejudices onto. That is the worst part of being a pain patient. It strips you off of your dignity and self-worth. What can we do, behaviorally speaking, and I'm going to talk about positive stuff in a second. What can we do to stop some of that transmission of pain to get through the dorsal cord, essentially through the spinal cord? What can we do to kind of muddy that so that all of that doesn't get into the brain? Number one, like I said before, educating yourself about your diagnosis and even about your prognosis instead of assuming other health needs, such as I'm paying for the sins of my grandparents, or I deserve this, or who knows what. It's really important to understand what in the world is really going on. That already sets the stage for being proactive and being able to do something that means something about your pain. Also, training your brain to respond to distractions. So for example, if you can train your brain to respond to guided imagery, meditation, yoga, tai chi, if you can begin to do these behavioral changes, in the end, your brain will respond to these distractions. While it was busy in a meditative state, it would not process pain that otherwise would have. What's the opposite of that? Sit there and concentrate on the pain, as a lot of pain patients happen to do. Physical distractions, changing your body position, exercising, stretching, using weights. A lot of times when we have pain, after a while, we end up walking in a different way. We hold our body in a compensatory way, which means we essentially guard ourselves in such a way to hold on to the part that was hurting before. Well, that doesn't help, but now we have this other thing that's gotten stiffened, and now we have another thing. So it's really important to be aware of these behavioral changes and engage in exercises. Physical therapy, of course, is one of them, in such a way that we wouldn't allow the pain to travel up even more. Cognitive stuff. So pain, you guys, is bad, right? You know, when you experience pain, you're supposed to get alarmed. That's what the brain says to begin with. So we often think, remember the part where I said the thinking part, what does it mean now that the pain signals is coming in? Typically we want to say pain is bad. Typically we're supposed to get scared and want to run away from it. So we think of pain, especially as it increases, we think of it in catastrophic ways, in threatening ways. Come to learn that that's actually bad for us. It says that people who anticipate the worst, pessimists, do have a lower level of pain tolerance. They experience pain worse off. So instead of saying things like, I'll only get worse, it'll get, what does it say, I will never be back to good again, I can't take this pain anymore, I need more powerful meds. Instead of this, you ought to be kind of thinking to yourself that I want to challenge. This pain is challenging, but I continuously will be looking for ways that I can distract it and that I can manage it. That way of thinking already inhibits part of these pain signals being into the brain. Some of the other cognitive distortions is, I must have no pain to be considered healthy. Ladies and gentlemen, it just turns out, as you saw in the slide before, pain is an inherent reality of our human body. We are and will live with pain. You live long enough, you will experience pain. So if you are from the belief that you're supposed to be living in a pain-free body, and if you do have pain, therefore you are unhealthy, you're cutting yourself a big hole. That's a problematic way of thinking. Instead, if you were to think, my doctors have assured me that even though I have pain, I can live my normal life. Or at least I will be living a life with a set of challenges called chronic pain or pain. That way of thinking changes your perceptions about these pain signals that are coming in. You wouldn't suffer as much from pain. And the other thing I really wish for you to walk away with nothing from the talk tonight, walk away with the concept of pacing. Chronic pain is actually kind of a fluctuating kind of pain. Pain in such a way that comes in like a scale of 1 to 10, you get a 10 one day, and then the next day at a 4. And it fluctuates back and forth, seemingly out of no good reason. So if you've had pain at a level of 8 or 9 for like a long time, and you've been lying on your bed, and you've been medicating yourself, and you've not been really able to participate in life, all of a sudden, if one day you're having just a 2 or a 3 pain level, what are you likely to do? Clean up the place, go to the movies, visit friends, vacuum the place, do this, do that, gardening. And then the next day you're at the ER looking for morphine shots. So the key is, even when you're having a good day, to be saying to yourself, great, I will do some high-impact activities, such as vacuum cleaning, and some low-impact activities, such as checking my emails. And then I'll get up and actually fold the laundry, and then I'll sit down and read a chapter. And then I'll get up and go for a walk, and then I'll come back and talk on the phone. So if you fluctuate your activities between high and low impact activity, essentially to pace yourself, you will get through the day with a lot less pain to report and a lot more than you have accomplished. Than if you try to jam it all in one day and you're having less pain more than this. So the concept of pacing is superiorly important. Should I stop at this point? I have some other, this is my last. It's just another quick little something to say. So. But I figured people wanted to break it.
You kind of don't have a break, then they...
Oh, you don't?
No. Yes,
Oh.
Unless you want a break.
No, I'm fine.
So
I just assumed that there should be a break.
No, we kind of decided in the beginning of class, we don't have a week to put 10 minutes over.
Okay. Oh, okay. Oh, then that's,
It's
this
all
really
good.
is my last line, and then we'll just be talking about stuff. Some of the other typical complaints or, stuff like me as much as before. I can't do the things that I used to. I am not useful. I'm no good. I see that in humanity very often. If they are unable to go to work, if they're not providing for their families, if they're not the man of the family, if they're not really fulfilling the familial roles that they used to, there is a sense of non-appreciation for the self, a sense of I'm no good that takes place in their lives. It's a no-brainer that you become depressed when that's the case. And we just said, the depressed brain, limbic system, depression, processes pain in a far more amplified way. It's louder in there than a non-depressed brain. So we invite people to be thinking in these other ways. For example, they would say to themselves, I'm still a person with love and desire and much to give. I am still a husband. I am still a partner. I am still somebody in here. And these are the ways that they would be kind of engaging their minds into what other ways can they contribute. How are they still there? Let's begin to look at that. Some of the other ways that people fall for these cognitive traps, if you will, is to say, in terms of sexuality, my spouse is not attractive to me the same as before, I can't be fulfilled with them. And come to find out that sexuality, or for that matter, affection, is not only through intercourse. There's 50 million other ways to be affectionate and be there for them. So you can say, I can offer my love and affection to my spouse in many ways. You begin to think that way. Another cognitive trap is, I shouldn't be working, I'll mess up everything. People shy away from going to work. Work is considered to be the enemy for people with chronic pain. Come to find out, you actually, in majority of cases, could go to work. You would just have to begin to develop a pacing schedule. Remember I was talking about pacing? So I had a patient who used to work 24 hours a week. That was her normal job schedule. She used to be able to do that in 2.5 days. I suggested that she went to work every day. So divide the 24 hours of work amongst the 5 days a week, but don't 3 hours a day, and however long you do it. But don't have the expectation that now that you've gotten there, you need to put in your whole 8 hours. You wouldn't be able to go back the next day. But if you can do 3 hours, come back, do the self-care stuff, eat it, cold it, stretch it, read about it, whatever it takes. Come back and go back to work again the next day. At least you're having 24 hours worth of income. So work is not necessarily enemy. The last one is this duo between the doctors and patients I was talking about earlier. The doctors should manage my pain better. They don't seem to care. I can't begin to tell you what a sick dynamic often you find between the physicians that are prescribing, especially narcotics, or the physicians that do injectables, and their patients. And imagine the referee role that I play as a health psychologist in between. So instead, it's much more helpful to say, doctors are doing their best. I keep on looking for new advancements, and I'll keep on looking after myself. These are just a few examples of how can we help somebody to change their perceptions and their belief systems about their pain condition from the stuff on here to the stuff on here. And this is where the role of effective psychotherapy comes in the future. So cognitive behavioral therapy is really good at getting people to take a look at their own belief systems about their pain, and then helping them to kind of reiterate other ways of healing what their pain means to them. And when you have been able to successfully change your thoughts or your perceptions or your assumptions, then by default your emotions change as well. If I don't think it is as bad as it is, then I really feel as alarmed and as threatened and as scared and as depressed. And when you have modulated the thought patterns and the feelings in the limbic system, you have automatically taken 2 parts of the brain. Remember we talked about how the pain is kind of processed in 15 movements. You have already processed 2 of the ways that the pain is perceived in a mindful way, in the direction that we want it to be. So that's all I've got. Now I'm all just ready for the fun. Yes. swing the question back to yourself. What do you think?
I think from based on what I know, I imagine better. It does affect me.
It is. So I used to work at Kaiser's Permanente in San Francisco, the Department of Chronic Pain. And these people would come in. This was a level 3 pain program, so this is like PZAC. Okay, that's what that is. So our narcotics of heavy dose, essentially med 24/7. If it's not because of pain, but because of the effects of the medication, right? So they would be coming in, and we would be having them to be off of their meds. And of course, you can imagine how stressed the person would feel and how threatened and how nervous they would be to be off of the 7 different kinds of medications that they're taking. So the pharmacists on board will take in all of their pain meds, and of course, amongst the team, we would decide on which one of them we want them on, which one of them we don't. But we would crush them and turn them into a liquid form, and we would just give them a little liquid in a cup. So they wouldn't know which one and how much of, but we would tell them that we are titrating you on. So in about, depending on the case, within 5 to 7 days, we would be titrating them down to the level, if any, of what we wanted them on. And at the end of the 7th day, they would either be reporting the same level of pain or a little bit less. So that probably answers the placebo question that we thought about. So, what comes to mind? Do you guys know of anyone in your life that is a chronic pain sufferer? Is it your experience that chronic pain is kind of like a year-long thing, like this has been going on, or relatively new? Or? Chronic pain, unfortunately, stays around for a while. It changes the family dynamics. It changes the person's sense of self. It definitely is comorbid with depression or anxiety. Yes?
In your practice, do you work with any kind of like sport injuries?
Yes.
Sport technology?
Yes.
Is that similar to what you were talking about today? Is there anything like that across that?
Yes, absolutely. Absolutely. As a matter of fact, when it comes, the question is whether sports psychology is along the lines of what I do, and if so, how would I approach persons who have been injured through a sporting activity and to the point where they're now perhaps not as able to participate in the rehab that they had before. Persons who experience injury because of sports kind of fall into one or the other categories. Either me, the casual tennis player who just goes, oh shucks, I can play tennis for 6 weeks, I guess I'll just get over it and go to yoga instead. So I have a better chance of healing the injury that's caused because of the sport. But then we have the hardcore sports people who are doing sports either as a way of living or as a very serious competitive sport. Then we're talking about all these sorts of negative thoughts and emotions. I am nobody if I'm not playing football. How am I going to be up to par with my peers? I have let down my family in many times. How am I going to get that scholarship that I thought of? I've been playing football for 4 years in high school, and right at the end of the time I was going to apply for college, now there goes all my dreams. So when those catastrophic ways of thinking are there alongside with the injury, we're talking far worse prognosis and far worse suffering or more suffering associated with the same level or same damage, same amount of damage. Yes, ma'am.
For people without an organic cause for their pain or previous injuries causing pain, have you seen that treating them in a therapeutic setting has helped the pain go away?
Yeah. You're using the word organic pain. Can you say more? What do you mean organic as opposed to? Sorry.
Like a physical cause. Like there's no physical cause.
Right. So let me make sure that, first of all, I know that this is not what you were asking, but let me just really emphasize and put it out there that we don't really have such a thing as real pain and also little pain. I know you didn't need to ask that.
I didn't mean it is not real, but
Right.
it's not like, I don't know.
Right, but, yeah.
My wrist and now that.
Right, right. Anyways, but yeah, so there's no such thing as organic versus non-organic. All pain essentially is organic. But yes, the answer to your question, oh yes, chronic pain programs, even better than mine, like at the Mayo Clinic or at the Kaiser Clinic. At clinics where they are multidisciplinary clinics, so that's really the biggest deal. You really need a team of providers to kind of put their arms around the patient, including the patient themselves. As long as you have a team in a multidisciplinary fashion, you've got pain. So remember how we were talking in here, it takes the changing of the thoughts and the emotions. Okay, that's where the psychologist comes into the picture. But it also takes like very good know-how of how to stretch, how to use your body. It comes to the picture then. Physical therapists. It takes changing the medications in such way that it's not actually causing more trouble than not. So that's what the prescribing physician and also even a pharmacologist, a pharmacist, they also come in the picture. It also these days, at least in Kaiser, they are now using heavily acupuncturists. Acupuncture actually happens to play a huge role in this. So in a multidisciplinary clinic where you have the body workers, you know, for example, physical therapists or the physical trainers, you know, those people who work in the gyms. And then you have the MD who's got their mind around the physiology of the pain. And then the psychologist who's got their mind around the psychology. If you have all these people kind of working together, oh yes, you get people. In fact, I have this one model patient that I always talk about with her, and then also, when she was referred to me, she was one of those 24/7 on heavy doses of narcotics. She's gotten to the point where now she's traveling to Hawaii, she's on no pain meds, she's definitely doing her flowering and cutting her. She's got a whole bunch of gardens, so she's able to actually get down. She's got tulips. She sells her flowers. I mean, she is out there. And this woman was on, again, a bag full of medicine, both narcotics and psychopharmacology stuff, like Prozac stuff and there's some stuff. She's taking nothing. And she's a lot happier and a lot more productive and a lot more like it. From anywhere it was kind of pain-wise or just as a human being. Now that she's not taking anything. And her pain level, you know, I guess she's got good days and bad days, and sometimes it's actually, in other words, she's not really the 116 million people that I was talking about. She's not a pain sufferer. She's just a person in pain, a person who has the challenge of having pain,